speak first then. Testing. Oh, it works. Good. Thank you so much.
You're welcome.
That's great. Okay, I'm going to put it here and test the acoustics. All right. Sip of coffee. Okay, good morning, everyone. Nice to have a chance to speak to you. For me, it's always a real exciting moment to see an incoming medical student class. I sort of remember what I was like at that exact same time and get to relive that in a vague way. So it's enjoyable. Today's talk is about challenges related to access, particularly at the lower end of the income scale. So the goals here are presented here. It will be helpful if, after reading the readings and going through this talk, you get to the point where you can characterize who's had and who lacked access to care before the Affordable Care Act, new trends in how access to care is obtained. Particularly important is that you be able to assess how the Medicaid program influences financial access, describe typical problems for people who lack financial access to care, and broadly characterize some of the competing views that financial access to care has on people. Let me say one point about the last item. As this talk got reconfigured over the last few days, a component describing the Oregon health experiment got smaller from prior years. It might even get skipped. So I want to mention to you that there's a reading posted. It's like a 3-page article that kind of explains what people have made of Oregon's effort to randomly assign Medicaid to people, what outcomes they've learned. It's very easy to read, and it's the kind of thing where I think if I don't present it, you'll quickly get it from that short article. The other thing I want to mention concerns tomorrow's disparity session. The exercise for the class involves breaking you into groups to discuss 4 different types of disparities. And you'll see that on the med map, the letters that are the first letter of your last name determines which case study to read. There's A through H, I through whatever, so it's broken into 4 groups. One is about a young African-American man who's had both criminal justice history and a bad event in the hospital and dies shortly thereafter. Another is about understanding Latinos' propensity to have poorer outcomes with diabetes. Another is about rising mortality among whites. I think another one is about African-American women and breast cancer mortality. And the goal for the class tomorrow with Dr. Charrington helping co-teach it will be to group you into little groups of 4 to discuss your case. It'll be easier if you actually read the case that is assigned to you. The case document is typically a newspaper article with some depth to it. It's not super hard to read. It should be interesting. Most of them are from the New York Times. Okay, back to today's topic. What is access to care? I guess the first question I have is to ask you, and maybe a couple people be willing to raise their hands and offer a thought, but what do you think of when I say we want to make sure that people have access to care? What does that mean? A hand went up in the front. Yes.
When people need medical care, they should be able to go get it without having to think about external.
So unimpeded getting to the care. Anybody? And that's certainly well within it. Any other thoughts of key components of access to care anybody wants to suggest? Yes, next time. So that suddenly we broke out that where the services are might be different from who's paying, and both could matter quite a bit. Final thought. Anybody? In the back? Nothing? It's okay. So just, I usually think of insurance, and this talk usually talks about insurance. But in the broad strokes, access to care, this is a model put forward by Ade and Anderson in 1974. It talks about health policy, which includes financing, but also manpower. So if we didn't have a bunch of new medical students being made each year, that could be a problem. Nursing students, obviously, educational policy. There's characteristics of a population that influence whether that, influence whether the population can get care. That's on the right. They talk about predisposing, enabling, need-related characteristics. These are things used in research models. characteristics of the healthcare delivery system. If you think about money and financing, it actually goes in both directions. People get money, but the system gets money. Both influence the access in terms of where services are set up, who's delivering it, et cetera. Those in turn influence utilization of service, both where they are and what the people have got and what they are, what their needs are. That influences their satisfaction. This particular model doesn't show the outcomes of healthcare, but that's all conceivably part of studying access to care. I think I circled where the money is, probably here to here and here to here. So when we speak of access here in this class, we're going to be focusing primarily on payment for individual services. We're going to somewhat set to the side all these other things that are really pretty important but just don't easily fit directly into one talk. But all of them can matter. A portrait of lacking insurance. This is from the National Health Interview Survey. Depending on who does the survey, the percentages differ. A lot of emphasis is put on people who are not captured by the Medicaid CHIP protections for children and not captured by the protections for elderly adults. And so we often will speak of access at the age of 18 to 64, where you see we were around 18 to 20% on insurance, dropping to 12%. Whenever you see a survey that gives you a figure under 10% of people who are uninsured, it's usually including these other groups. I don't think there's much more to say about it. Obviously, the Affordable Care Act played a big role in the drop in the figures. Big picture is worth understanding that most of us still rely on employers for health care access, or at least financial access. Medicare is a pretty big player. And my focus is more on Medicaid, uninsured, and CHIP, which have gotten a little less treatment in the curriculum so far. I hope that's still the case, right, Tom? Yeah. Another couple numbers. In 2013, 41.3 million people lacked insurance. In 2016, 20 million lacked insurance. The number, if you did a subtraction problem, you would say that's 21.3 million obtained insurance. The calculation that more obtained insurance has something to do with population growth or changes in demography. So it's always a little confusing to look at that, and that together. But whether all of this change is entirely due to the Affordable Care Act, we can debate around the margins. Okay, this is an interactive question. What is typically true about lacking health insurance in the U.S.? Do I need to press a button to help them vote? Okay. So people lacking health insurance can still get health care when they have to. The majority of people without insurance lack a primary care doctor. If you're uninsured, you're more likely to postpone or forego care when it's needed. None of the above. All of the above. Do I need to press it now? Oh, did I screw it up? Sorry. Oh. Polling is open and responses are coming in. The intriguing thing is graphs usually appear at this point. Is this a secret ballot? Okay. Secretly ballot. We won't interrogate you about what you said because it's probably at the last minute when they fix the slide, something didn't get turned on. I'm just going to, a little disappointed in that. Should I do show of hands? Come over here, Tom. Help me out. I don't see it. Or can I click something and it'll show me? Click responses.
No. See, that tells you how many people have responded.
Yeah.
So once it gets to a reasonably high number, you just end it.
Oh, end it. Will it then show?
It should.
It should. 119 sound high? Okay.
Let me just say I'm going to end it in 5 seconds.
I'm going to end it in 5, 4, 3, 1. All right, skip one. Polling closed. Okay, all of the above. So most of you think people can still get care when they have to. They probably lack a primary care doctor. If you're uninsured, you're probably going to forego. It's funny that I made a logic flaw in the design of the question, because if you say all of the above, you've also endorsed none of the above. Kind of go into an alternative universe where those two things can be true at the same time. This is survey data from, I guess, Commonwealth or Kaiser Family Foundation. All of the above might be right, I said. So not having a usual source of care is much more common among uninsured people compared to people with Medicaid or employer other insurance. Postponing seeking care due to cost is more common in that uninsured group. Went without needed care due to cost and could not afford prescription drugs. So a lot of the things that you endorsed probably look like they're true, except for none of the above. Sorry about that. But, I think sometimes there'll be a discussion about what is exactly that Medicaid in particular provides. And when one looks at patients' reports of their sense of access to care, it tends to be not quite as good as what the private insurance does, although not on this one, but pretty much different from being uninsured. I want to skip the managed care organizations for a moment. So I wanted just to have you guys think about what would happen for a person. This is really a case from before the Affordable Care Act. A 39-year-old analyst who works for a museum makes $39,000 a year. No insurance is offered. She notices a lump in her neck. This is a real person from 10 years ago. She goes to a teaching hospital where she gets a visit to a specialist, has an ultrasound and a biopsy of what's in her neck, and they tell her you have thyroid cancer. The challenge is all those tests were done without her being able to pay right away. And the hospital called in a collections agency to try to get back what they feel they lost on her care. Endocrinologist said, you know, you're going to need surgery for this. The surgical clinic at the same hospital says, you have unpaid bills. We can't see you. So I just wanted to ask the class to volunteer some ideas about what you'd suggest if this woman was your friend. So could she go into the emergency department, invoke EMTALA, and say she needs emergency care? At a certain point in the history of the neck cancer, she could, but it may be tricky early. They may say, well, we've stabilized you. I think we're going to come to EMTALA. I think they have to stabilize and then sort of let you go. They might say, well, it's very stable. Yes? To get charitable care. So there's a lot of, most nonprofits are going to have, maybe even for-profits will have a charitable care program. She can apply and see if she'll get in. I put her salary a little higher than the thresholds for charitable care programs. But that doesn't mean it's impossible, and I don't know the rules of every charitable care program. It could be possible. Anybody else? Yes? Yeah, GoFundMe. I don't know if you can do Kickstarter. I think you have to deliver a product at the end. But yeah, you could go to your church. You could seek money. You know, in Kenya, when I was there, people always had a harambee. You know, when somebody needed surgery or was coming back from the hospital, we have a harambee. And that meant the whole community had to come together and pull together the money, often to pay a bill that was already accrued at the local hospital. I think we've gone through most of the typical options. Let's see what I threw up. Did we talk about income and insurance? Sort of. Did we talk about emergency departments? Yes, we did. Did we talk about safety net clinics? Well, we didn't. There may not be a safety net thyroid surgeon. Probably a safety net primary care clinic. We didn't talk about hospital policies at this part, and that's probably we're setting it, but we hinted at it with the charitable care aspect, that hospitals kind of make a decision, how are we going to handle these people? Some hospitals will say, your visit begins only after you pay a fee at the clinic of $20 or $50 or $100. There's been research to show that from hospital to hospital, whether or not those policies are even enforced by the front desk staff is totally variable. There can be a sign posted that everybody has to pay $30, and then the clerk basically says, oh, no, if you can't, go ahead in, it's fine. And then in another hospital, there's no sign, but they quietly insist that the person pays. And this has been studied by having people follow patients through individual hospitals. Getting care at the emergency department came up. Hospitals have to screen and stabilize for an emergency condition. The important thing to recognize is care isn't free, even in that situation. The hospital accrues an expenditure, they account for it, and it's uncompensated if the patient can't pay. And they break it down as an accounting matter into what they chose to give for charity and what they call bad debt. And both matter. And in 2010, uncompensated care for hospitals was $39.3 billion. It's interesting, I think the cost of the Medicaid expansion this past year was $75 billion. But it's a serious amount of money. And some of it they are going to use to justify their nonprofit status, and another part they're going to use collections agencies and try to get it back. A little bit of history on the safety net. Anybody know what this is? The question is if I know what it is. Yes, help me out.
That's a plague doctor.
Yes, that's exactly it. They wore these beaks And I think the smells were so foul, they put stuff in the beak to, mint and things like that to distill the terrible smell of London during the middle of the plague, or whatever city this plague doctor was caught in this quick photo op. So before 1950s, the way we looked at care for vulnerable populations was really typically through charity and alms. They're typically ad hoc civil organizations, religious organizations, voluntary effort. Even some of today's important hospitals started as charitable hospitals, like Massachusetts General Hospital's religious function type of hospital. Almshouses usually were a place to land if you didn't have a place to go, poor, aged, insane, and disreputable. But many of them then evolved into the hospitals that are quite famous in the cities where they are located. So Bellevue, Charity Hospital, now it was called Big Charity for a while. The building closed down. Is anybody here from New Orleans and can tell me they moved it over 3 blocks, right? But essentially it's a gigantic hospital. The building's still there. Philadelphia General. The history of the Philadelphia Almshouse gives you a sense of this sense of sort of obligation of people they didn't really want to have to take care of, but then did. The dependent class increased in such number to such an extent that the overseers of the poor presented a memorial. I think that's a resolution explaining how problematic it is with all these poor people coming in. They said there should be help for these people in an almshouse, and then they add in that in addition to the almshouse, there has to be a hospital for the sick and insane, and that's the Philadelphia Hospital. But that changed as medicine professionalized, particularly during the 19th century when we went from sort of everybody can open up their own kind of practice, a sort of quack medicine, or maybe some of it was good medicine and surgery, to it's a profession. And in that process, hospitals really came to the fore. And the Johns Hopkins Hospital was not an almshouse. It was going to be a university-based, house of teaching medicine in a scientific way. So the general theme of our care for people who might otherwise lack financial access was efforts to formalize the organizations of people unable to pay. Most importantly, community health centers, subsidies on the exchanges, and Medicaid. And Medicaid has really been on my mind because it gets to be a larger and larger part of our political discourse. If you've been watching the news, have people noticed that? A larger and larger part of the budget, and a larger and larger part of this very talk, such that it's almost pushing out other sections. And I have been trying to scratch my head trying to understand why. Why is it that Medicaid is growing the way it is? And I think we can answer the question, but you need to think deeply and historically. Medicaid was started in 1965. That's history. What else started in 1965? Yeah, Dr. Dre. Dr. Dre was part of NWA. What's their most famous song? Straight Outta Compton. So to understand Medicaid and its impact on us, we really need to go to the lyrics of Straight Outta Compton. No, not that one. Let's go to this one. So when I'm in your neighborhood, you better duck. Duck. No, neighborhood. What do you think of? A neighborhood. But neighborhood is also the name of one of the most important Medicaid health plans in Massachusetts. But we have 2 clues in the very same line. Because duck, what do you think of when I say duck? A duck, actually, yes. But what state is famous for its ducks? Oregon, home of the Medicaid experiment and many other innovations in the Medicaid program. So now we're beginning to see a bit of a pattern here. We have Oregon and Massachusetts right on the map, but we are not done yet with NWA because I forgot one other key component of NWA who was, yes, Ice Cube. And where do you go to get ice cubes? Northern Canada. It's very, very cold up there. Back to the map. So I submit to you, this problem has solved itself. We know why Medicare has become as powerful as it is. So there you have it. Okay. If it's the case that it's not the Illuminati that have caused Medicaid to grow in the way that it has, we're going to have to look back at a different kind of history. In the 1950s, federal grants were sent to the states for care of the poor, but they were not very much used. Federal grants for states for medically indigent elderly were expanded under the Care-Mills Act of 1960. You had to be truly poor. Just 28 states used them, and they didn't take very much of the money. Just 1% of the elderly were benefiting from these programs. And this is now 1960 where they're talking about this. And really in 1965, the same year that Dr. Dre was born, they passed the law, essentially the amendment to the Social Security Act, which added Medicare and Medicaid. What was in that law? It's kind of a compromise of a lot of different political forces. They call it a three-layer cake. A payroll tax for hospital care, sort of a single-payer system in a way, pulling off of people's paychecks. A voluntary program that people didn't have to join for doctor's visits, which would be covered by a mixture of fees and general revenue to supplement it. And this was Medicare Part B. It's kind of like insurance, which is what many doctors are more comfortable with. And finally, a federal grant to states that was going to be a lot bigger for medical care of the indigent elderly and certain other groups, an extension of that Care Mills Act, Medicaid. Sort of 100% subsidized insurance, sort of an almshouse. That's the third layer. Medicare was clearly seen as a different thing. Social Security had been started in 1937, income security. It was considered earned. Everybody deserved it. And it was and because hospital costs, hospital insurance became quite pricey from 37 to 65, as they were changing the way they rated insurance policies for hospital care, was getting very expensive. So there was really a sense of need to get that Medicare part covered. It was a little European in its outlook. Medicaid was a bit different. It was a patch to those state indigent programs where the feds would cover 50 to 80% of the state costs, depending. And there were mandated groups that had to be eligible for Medicaid. And at the start, it was poor families on cash benefits, at the time called Aid for Families with Dependent Children, now TANF, and those who were aged, blind, disabled, and were receiving income support because they had fully qualified as disabled under federal rules. And other groups were optional. It's an entitlement. Anybody want to talk about what the word entitlement means? It's a little bit like a right, I think. We never used, but they didn't say right. And Dr. Huddle teaches an entire class on how to define what a right is. A right is a philosophical concept. Entitlement's a little more mechanical. Other thoughts on entitlement? Does it sound good or sound bad? It almost sounds bad. Like, give it entitlement. You have an entitled attitude. An entitlement is something where if you're in the class, you're entitled to receive it. That's the core, is that once you meet the criteria to be in the class of whatever it is, you are entitled to get it. And it kind of implies an open-ended commitment on the part of whoever has to provide it. If more people are in the class, more people get it. There's no fixed dollar commitment in Medicaid. If there's more sick people, more old people, more costly treatments, or if there's an economic downturn and suddenly everybody needs it, more money has to be spent. Medicaid is inherently open-ended in its current design. And obviously, if you were reading the news in the last 6 months, you saw proposals to try to make it less open-ended. Medicaid expansions in the 1980s included pregnant women and children if the family was poor. Many states reached pregnant women who might be under 200% of poverty level, under 300% of poverty level. That was a group that was seen as easy and socially acceptable to immediately offer support for. Coverage of all children with families under 100% of federal poverty level. That was mandated. So if you're a kid growing up in a poor family, you're going to get access to Medicaid or later CHIP, even above 100%. Maybe not your parents, but the kid. Some implications of how Medicaid is set up help us understand where the money is spent. Healthy kids don't cost a lot. So they're a big part of the program, but they don't cost very much. Most money goes to the elderly and disabled. States sometimes made it tricky to sign up and qualify for Medicaid, so a lot of kids in poverty didn't get it. In 1988, it covered half of poor kids, under half of poor kids. And I think in 1985, I don't know why it's just another statistic from the same period. It just showed that we were missing a lot of the poor. In 1997, after the failure of the Clinton plan, there was an effort to push insurance out to kids who might be above 100% of the federal poverty level, and that was the CHIP program. It can be part of Medicaid or it can be separate. Every state configures it differently. It does include dental care, hearing assistance, glasses, and the thresholds vary across states, but it really effectively reduced the percentage of kids who are uninsured substantially. A little extra on nursing homes and the elderly. 15% of the U.S. 65 years and older. That's obviously a rising number. People are going to need nursing homes. Medicare only does that short term. So when we talk about Medicaid, we're talking about nursing homes. And remember, there's no fixed total dollar amount that the government's going to spend. So nursing homes are a very big part of the Medicaid docket, and Medicaid is a big part of every nursing home's income. Children, I think I've emphasized this to a significant degree already, but Medicaid is this green part. 39% of kids covered by Medicaid. Roughly half of childbirths are financed by Medicaid. So now you begin to see this, how big this is, whether or not the Illuminati were involved. And Medicaid changed as a result of the passage of the Affordable Care Act. One of the key components was initially mandatory, but after a Supreme Court ruling, voluntary option for states to expand eligibility to Medicaid to adults who fell below the threshold of 138% of poverty. And that is $28,000 for a family of 3 in 2016. And my last numbers show 32 states adopted that. It costed $74 billion. Remember the $39 billion for uncompensated care 6 years earlier. And Medicaid obviously grew as a program substantially. And as I made this slide, I sent Tom a text. I said, you know, this is how you show the map of the states that adopted. But I also feel bad. You have to get used to blue and orange. Tom reminded me not everybody likes that, so I put this up to make you feel better if you're an Alabama fan. Okay. Medicaid has got some other implications that are quite important today. Most notably, we're in the middle of an epidemic of addiction in which the opioid drugs, but also alcohol, are quite prominent. So there's an element of Medicaid and the Affordable Care Act in how mental health and addiction care are provided. There was a law in the books from 2010, maybe even 2008, it's probably off by 2 years, that said if you're a large employer offering health insurance and you have a mental health benefit, it has to be equitable with regard to other types of care. You can't have a really puny mental health care benefit and regular medical care. You could say, we don't offer mental health, that's okay. But the law said once you offer mental health care, it has to be equitable. It's called the parity law, or the Wellstone parity law. But it only applied to large employers. But ACA basically said, you know what, we want this parity applied to everybody. And I think they even mandated that mental health be covered in most of these settings. So currently, 25% of all the medication treatments for opioid addiction, drugs like Suboxone, are Medicaid funded. And in Ohio, which is one of the epicenters of our current overdose crisis, it's 50%. That's why you heard so much discussion of $45 billion set aside for opioid care in the various renditions of the Republican versions to roll back the Affordable Care Act. It's like we have to figure out how to deal with the fact that states are depending on this money. There still is a gap in coverage even after the Medicaid expansion that's called the coverage gap. And it took me a while to understand it because it depends where you live. Medicaid, as traditionally configured, is limited to specific low-income groups. And if you happen to be in, I don't know, Massachusetts, there isn't really a coverage gap unless you're an undocumented resident, illegal alien, whatever you want to say. But if you're in states that didn't adopt the expansion, there's a coverage gap here because some individuals will have an income level below 138% of poverty, but they also won't be able to qualify for Medicaid. There's also an implicit coverage gap here where the marketplace subsidies are supposed to operate. Because if your income is not qualifying for very much subsidy and the price for the plans being sold in your particular area is very high, you also fall into a kind of coverage gap. But as you've heard, some of the agitation to change the Affordable Care Act was really focused on this group. And then if you listen to me, you'll hear a lot about this group. Medicaid income eligibility limits for states that have not implemented the Medicaid expansion. So we're in Alabama. So essentially, to be a poor adult who has kids who are poor, those kids qualify. But for the adults in that family to qualify for Medicaid, they'd have to make 18% of federal poverty level, something like $230, $240 a month. Make $400 a month, you're not going to get it in Alabama as a parent. As a single adult, it's not on the cards. And that's partly the residue of many, many years of some states expanding Medicaid and saying, for single adults, we're going to go ahead and offer. Wisconsin, look at Wisconsin. And other states saying, no, that's not part of what the original program is, and we don't want to pay additional funds that we can't find for that group. Medicaid is growing in cost, however, and that poses a budgetary challenge. So what you see here is expenditures per recipient in the lower line, and one gets the sense that perhaps this is, not a high rate of inflation per recipient. To be fair, there's a lot of kids in Medicaid, and maybe they just aren't very expensive. Then you see the growth in the number of recipients, and that seems to be pretty aggressive over these decades. And then you see the total expenditures, and that is rising quite quickly. And so, from a budgetary perspective, this does raise significant concern. There's been some hope that managed care organizations involved in Medicaid will do things to change patterns of care utilization that would reduce the rate of growth of expenditure. There's a reason to be a tad skeptical, which is that the rate of per-person expense has not risen very fast. Traditional fee-for-service is to any willing provider. I know that Thomas talked about that a lot. Medicaid rates are often low. By 2010, I think 70% of Medicaid beneficiaries were in managed care organizations. But the most costly groups, like the aged and the disabled, were not. And maybe that's where the money savings could be made. The promise of managed care organizations in Medicaid is that they could impose some accountability and savings. But how they work, what money they get, which parts of the care they manage, do they manage the behavioral health care, or is that carved out to another organization? All of that varies by state. When I was in Massachusetts, taking care of homeless people who all had Medicaid, basically there were two or three managed care organizations, but several of them were pretty much hands-off. When I recently visited a Healthcare for the Homeless program in Baltimore, which also expanded Medicaid, Healthcare for the Homeless Clinic had 9 managed care organizations that it had to get authorizations from. So they hired 4 staff to manage their interactions with 9 managed care organizations to make sure the referrals went through. So you think, okay, that's pretty complicated, and that's quite a bit of expenditure for something that's going to be adding efficiency and controlling costs. Most studies have not really found cost savings thus far from these. Why is it that managed care organizations haven't really saved a bunch of money? What they do provide is some predictability. They provide a little bit of insulation from risk from the perspective of the state. But fundamentally, Medicaid is per person, not very expensive, and states simply have to balance their budgets every year. So they will cut the program in various ways if they have to when the budget is stressed. And there's some additional, and I'm showing you the relative rate of per enrollee cost growth between Medicaid, Medicare, and private insurance. So you'll color me a skeptic. You may hear contrary arguments, which are fine, but I tend to not think that we're going to reduce that rate of growth much more since it's already a lower level of growth. Per capita caps. I'm thinking I might want to skip that. That's kind of a hot topic, but I'm not very excited about it. Tom, do you think we should just let it go or let them know what it is? That's the thing. It's a legislative proposal that hasn't passed. Essentially, the idea would be, what if states were told, look, we'll give you a fixed amount of money per participant in Medicaid. You get more people in it, you're going to get more money. But we're not going to let the rate of growth exceed a certain amount per person. It can grow a little, but not a lot every year. And I think the proposed rates under certain plans what went forward before the Congress were a little bit above the normal index of inflation. Medical inflation tends to be a lot higher. This was a little higher than the regular rate of inflation. And so there was some anxiety that the effect of this would be to cut the otherwise projected trajectory of funds for Medicaid over the years. And if you're on the liberal side of the spectrum, you refer to it as a $780 billion cut. If you're on the conservative side of the spectrum, you say, no, funds are still continuing to grow, just not at the rate that you wish they would. Another element of the safety net that I think is worth understanding, or at least hearing a tiny bit about, is community health centers. This is not a payment mechanism, but people who are uninsured could go to them, and they would receive federal grants. And they were started as part of the war on poverty, and there's a picture of Dr. Jack Geiger, who was involved in founding the first community health center in Mississippi, and also the first one in Massachusetts. And there are 1,300 now, and they serve a lot of people. And the way they work is that they get a federal grant, and they can build Medicaid. Remember the thing I said about how Medicaid doesn't pay very high rates? That's not the case with these community health centers. They're allowed to bill a full and generous rate of care for every Medicaid visit. So it's actually can be reasonably profitable to be a community health center seeing Medicaid patients. A subset of those folded into all of the other community health centers are healthcare for the homeless programs. That's where I got my start. Where I was in Massachusetts, I had consent from the patient at the time. I even got it written at the time, and I took his blood pressure. And payment issues were non-existent. Managed care was a part of our life, but it wasn't a very big part of it. Those provisions have changed, and I think Tom has a lecture on changes related to the Affordable Care Act. Some of them are summarized here. I don't think I'm going to go over these. And is Dr. Curry giving a full lecture on this issue? Or mostly you? Okay. Okay, so who's left uninsured? This is a stat from 2013. It's about 15%. I think we had 12, 13% before because the year changed. We're left with the question of whether we can expect insurance to improve health. I heard a little bit of discussion about that when I came by a lecture yesterday. Anybody want to offer their current working hypothesis on whether health insurance will improve your health? Where you at? Or where you at, if you're from New Orleans? Yes?
I mean, in theory, it should, but I think unfortunately we have a system, like we talked about before, that's like a fee-for-service, and that's not a preventative care system. So theoretically it should, but we don't have a preventative care system in place.
So the theory there is that the system's set up to reward taking care of people. The sicker they are when they're taken care of, the more money that can be made. And doing a lot of the things that might conceivably improve health is not a very profitable activity. I'm open to that theory. Other theories? I mean, this is not a right or wrong answer here. Yes? Yeah. I like that contrast between the sort of, I have an amazing crisis that could kill me within 6 months, please save me, which happens to such a small percentage of people, but is really pretty important to you when it happens. And the U.S. system seems to have enormous capacities. On the other hand, if you say, well, we're just going to sprinkle some insurance across the society and see what happens, you know, the claim is a little more tenuous. Yes? Yeah. So, I mean, I would call that one reading of the Oregon Health Service study, and I'm going to give you the couple little findings, and we'll sort of entertain that. There are different kinds of studies and many different papers. I think there was even a review by Atul Gawande suggesting, you know, when you look across all the data, health insurance improves health. But I favor giving you a chance to just absorb a little bit about the Oregon Health Sciences study. And no, I don't endorse medical marijuana. Now, what was the Oregon Health experiment? As I read that piece in Health Affairs, I didn't quite understand why Medicaid had been randomly offered, but it was because they had accidentally pulled too far back and too many people had dropped out of something called the Oregon Health Plus program. And then they realized they could open it up again, but they couldn't possibly open it up for all the people who might qualify. And so they said, look, let's randomly offer a chance to apply and be deemed presumptively qualified if you met certain criteria. And the analyses that have typically been published looked at the Portland subpopulation rather than the entire state, which could prove to be important when we talk about results. Medicaid was essentially offered to 10,450, not offered to 10,340. The average duration of the Medicaid experiment in the results that I had checked for this talk was about 18 months of impact. And they tried to look at statistical models to see what was the impact of gaining Medicaid, given that not everyone who was offered actually completed the paperwork and got into it. And they had about 2 years of follow-up. Looks like they had 18 months of exposure and 2 years of follow-up. Those are the studies I looked at, and the results didn't change much even a year or two later. It is worth saying that what the impact is of offering Medicaid to people in the city of Portland might be different than on a country basis. And to the extent that health insurance is really important for these incredible disasters, like my liver just failed, please transplant it, you might not have many of those disasters in the population that you're studying. But what they did find was kind of a mixed bag. Medicaid clearly boosted the amount of health services used. Medications, office visits, preventive services, and emergency department visits all went up. People made the decision to come in if they were in the Medicaid group. Medicaid receiving individuals proved no better than controls on blood pressure, on cholesterol, on blood sugar. They weren't even more likely to receive blood pressure treatment for high blood pressure. But when I looked at the data, I saw that almost everybody who was uninsured was also receiving treatment for high blood pressure in Portland, as were all the people who were insured, which is different from what you might see in Alabama or in a place where there hasn't been a history of robust community health center development and publicly subsidized care, where you might find that the likelihood of being treated for those is low. So there's a chance that the control group effectively had some benefit from what was in the community. The Medicaid group clearly avoided financial disasters. They felt better in some scores of depression symptoms. I don't know whether having Medicaid makes you happy. Receipt of diagnosis and treatment for certain conditions was more common in the Medicaid group. Self-reported general health, they ask you, is your health excellent, very good, good, fair, poor? That's 5 categories. And that scored better in the people who are in Medicaid. Financial stress and saying you had a primary care or usual source of doctor were better. So we're close to the end here, but kind of a thought question. What if, as a society, expanding insurance to all offered a major reduction in financial risk, a moderate improvement in care access, a modest outcome benefit for some diseases among the small percentage of people who have them, and no overall impact on the health of the population? Because I heard Dr. Durant said that health services might only be responsible for 10%.
Well, he said 15, and other people say 10.
Okay. So what if this were the case? What if this were reality? First of all, does this, I don't wish for you to assume that I'm going to test you, that you have to cough this conclusion up on a test. Because if you open New England Journal of Medicine or JAMA, you're going to find articles by pretty strong advocates who are not going to take this view, who are people I respect, who I think are also looking at a broader literature than the Oregon experiment. And I certainly can see their point. At the same time, what if this were true? Do you guys have reflections on that, or whether is it worthwhile to expand access under these conditions? Does it change how you think about the problem? Are there any free reflections about this notion that maybe we could be doing something big that helps in one way, but maybe not as much in another? There's nothing, again, no right answers here. Just curious how this resonates. Yeah. So if a major stressor were simultaneously removed from the lives of 1 million people or 18 million people, and mental health is somehow tied to your physical well-being and functioning, shouldn't that convey a result? And to take your view, I would say it could be that let's say it's a 3% improvement in health expenditure, in certain kinds of bad health outcomes. And in a study of about 20,000 people in the city of Portland over 2 years, that size of a benefit may not be detectable. You may, in order to see a 3% improvement in something that is indirect, sort of, you may need a population of millions to show that effect and see it statistically. Conversely, I guess somebody else could argue, that's a nice hypothesis, now prove it. So I can make it plausible, but I can't say it's exactly proven. Tom?
So, Stefan, how could anyone look at that question up there, and if what you're asking is, if expanding insurance did A, B, and C. Should we do it? How could anybody possibly say no?
Well, I mean, if I have a fixed number of dollars to spend to improve health of the population, and there was something else that we're 100% clearly likely to do it, I don't know.
If all we're interested in is improving the health of the population, we're going to spend money on changing the social determinants of health, and we're not going to spend money on health care at all.
We could.
Clearly, we're not going to do that. We're interested in people being taken care of when they're sick, right? So the answer to this has to be a no-brainer, does it not?
Well, I think it comes down to a matter of relative priorities. I personally, I mean, I hold down the view that I want nobody to suffer an adverse effect because we couldn't cough up the money to help them get their blood pressure medicine for 10 years, and now they have a stroke. To me, that's just a devastating tragedy and it's a personal value statement. I think it's a bad mark on us as a society when I take care of somebody with a stroke whose child says, Mom couldn't take the medicine because she couldn't afford it. Conversely, I think if you have a fixed pool of dollars and you have something you know might save a whole bunch of babies' lives or something because it involves changing the water supply or building, I mean, none of this is proven, but making sure everybody has an opportunity to exercise every day, there could be things that should pull funds away from this emotionally compelling mission to me and say, well, this will actually prevent this many kids from getting diabetes, and we should be willing to spend money on that. So do you want any other thoughts? I mean, it's sort of...
So you're wearing your public health hat.
That would be the
you're
public
wearing your
health hat.
population health hat.
Yeah, but that's a secret hat. And my real hat is that I want everybody to get access to care. Go ahead. Yeah, I mean, as a doctor, I want to say if you pour money into the people in need who I take care of, that is the best thing to do. I think it's just appropriate to recognize that many people resonate with that, whether they're doctors or not. That's why people can have fundraisers for illnesses and sometimes pull together enough money to deal with it. But it's open to challenge. And if you have been arguing, I am sure that the entire health of the public will improve by virtue of expanding personal health insurance through my plan, and I'm sure it will improve more through my plan than by about 1,000 other things you can do, you're going to be subject to challenge in those assertions. And I think I sort of want you to feel the tension. Some of this is, I have a raw emotional resonance with this. I think a lot of people do. But at the same time, I'm not saying the Oregon Health experiment is the be-all and end-all. It's just a nice model to get into the discussion that you're going to continue as you look at other resources and other people commenting on this. Effectively, we're done.
You got 2 minutes.
We're effectively done. I just want to mention, there's a reading going to go up that we're trying to get to them about the pre-ACA. Yeah. Oh, good. So in terms of readings, I put up a blog that I think is kind of cool on contextualizing healthcare, just in case you're interested. It's not required. You won't be tested on it. There's a chapter that is, I admit, I scanned it personally when I was in a rush, so the pages are a little diagonal. But it's a book chapter from a book before the passage of the Affordable Care Act that tried to explain the patchwork services under conditions of lacking in insurance. And that might be worth looking at. I probably will. My guess is I'll talk about something about that in one of the test questions. And that's probably it. Do I have extra slides? No, I don't. Any final questions about what I've said or areas of unclarity? Yeah. So Medicaid, I think only 50% of doctors or so will accept the rate of payment that's offered in their state. So it's low cost, and that means that it can be hard to find a doctor. Actually, this can also happen with Medicare at this point in time, depending on where you live. There are regions of the country where the Medicare rate is low enough that some doctors will say, it's going to be more workable for us to do just employer and private insurance and not deal with the Medicare population. But Medicaid is particularly challenging in that regard. And I think that's why when you looked at the percentages of people who had regular source of care, you saw that Medicaid was almost as good as private insurance in some of those access indicators, but not as good in most of them. And I think that's partly what's going on.
I mean, another way to look at it is that Medicare and Medicaid both are pouring a cataract of money into a fee-for-service system such as we've previously discussed, and the amount of money is simply becoming incredibly burdensome without sort of being, quote-unquote, enough. And states deal with it in different ways. 40% of doctors don't accept Medicaid, which throws an interesting light on our supposed commitment to social justice. But the reasons that they don't, have to do with the limitation of the fees. And states either lower the amount of money per service that they're going to pay doctors, or they limit eligibility. I mean, it's a very interesting point that you didn't really make, but Alabama, for instance, it's really hard to get into Medicaid. But once you're in Medicaid, you're better off because the reimbursements to providers are better. The red states generally have taken that approach. They have much lower they might have much more difficult eligibility thresholds, but they pay the providers better. The blue states, where everybody's covered, or many more people are covered, the Medicare reimbursements to providers are horrible. Medicaid reimbursements to providers are horrible, and even more providers in those states just don't even see Medicaid patients. So this is just a huge problem. And I would want to argue we need, this is not going to be fixed until we change the system, until the cost, the cost of medical care is the real problem here.
Is that enough? Should we stop? Yeah. I thank you for your attention. I hope you enjoyed it. Take a look at the readings. See you tomorrow.